Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good morning, everyone. Thank you for joining us today at our special edition Lung Cancer Living Room, coming to you live from Medscape's virtual lung cancer conference. I'm Danielle Hicks, Chief Patient Officer here at the GO2 Foundation for Lung Cancer. And for those of you who may not be familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind, with the goal of bringing to you live and in real time educational talks from key opinion leaders in the lung cancer community, and in a format that's really, a format and a language that is easy for you to understand. We know that people watching come from around the globe and consist of patients living with varying types of lung cancer. And today, what we're going to be discussing is the approaches to the management of small cell lung cancer. It's a very important topic that is near and dear to my heart, and the GO2 Foundation, as well as to the heart of our speaker, Dr. Jacob Sands. Dr. Sands is a thoracic medical oncologist at Dana-Farber Cancer Institute and instructor of medicine at Harvard Medical School. We couldn't be more thrilled to have him here tonight. Let's start with sort of on a basic level. What is small cell lung cancer, and how is it different from non-small cell lung cancer?
This is decades ago, really at the beginning of understanding cancer diagnoses and to differentiate these. Under a microscope, small cell lung cancer cells are smaller, and therefore these were separated out as small cell and non-small cell. Now, that being said, all cancers are essentially cells that are mutated. So we categorize these in ways so that we can further understand what is generally good treatment options. And that being said, these cells that are mutated really can be somewhat independent of those boxes in some ways. So each person's cancer needs to really be individually evaluated in the same way that we take into account the unique traits of each individual that has that cancer. But when speaking broadly, generally, small cell lung cancer tends to grow more quickly than non-small cell lung cancer. It tends to also respond very quickly to initial treatment. So the fact that it grows more aggressively also makes it a bit more susceptible to those chemo agents in the beginning. And so the responses can actually be quite dramatic as well. And so there are different characteristics in each of these. And I know we're going to get into some of the specifics that we take into account in treating small cell lung cancer. But just generally speaking, under a microscope, these are smaller cells. They look different. And thankfully, although it grows more aggressively, the responses to initial chemo are often typically quite rapid.
Let's talk a little bit about staging, because typically small cell lung cancer is staged a little bit differently than non-small cell lung cancer.
That's right. And I think for most cancers, we talk about stage 1 to 4. And that exists for small cell too. But more commonly with small cell, we tend to talk about it as limited stage or extensive stage. And what this really comes down to, for the most part, is, does it fit within a radiation field? So this starts out as a lung mass, a nodule mass, and lymph nodes within the chest are often what's involved next. No, that doesn't. There's no absolute of how everything goes. So as I said in the beginning, we're talking about mutated cells, and so these cells can act differently. One cancer is not necessarily exactly the same as another, even though they're categorized all as the same type of cancer. So limited stage being the nodule or mass in the lung, and lymph nodes, if they're involved within the middle of the chest. If all of that area can fit within one radiation field that can be safely delivered, then that ends up being limited stage and typically is treated with chemotherapy and radiation together. And the goal is cure. Now, there can be very limited stage. I mean, that's not an exact category. I'm just saying very limited in the fact that there's just one nodule, and therefore that might end up getting surgically removed, and so that can also be a treatment. And that still is categorized as limited stage, although those cases are unusual to catch small cell that early. So typically, we're talking about something that would be treated with chemo and radiation, and that ends up really being the cutoff. Extensive stage is something that is not really considered curable. That's not to say that it can't be controlled for a long time, and we'll get into some of the advances that have happened in that setting. But at least classically, this is not considered curable. There are some instances of people really having very long control, and some questions about maybe, which is exciting, and we'll get to that. So that's kind of the general separation and the general goals of treatment.
Are the symptoms different for small cell lung cancer than they are for other types of lung cancer, or are they virtually the same?
The symptoms are so different and not necessarily entirely reliable in that I have a lot of people that come in who have no symptoms, that they just have this that showed up in some other testing. A guy I just saw actually this week who has stage 4 disease but has no symptoms, and this was only caught because of something with like a head and neck kind of evaluation where the scan for that got the top of the lungs and showed some nodules in the lungs. And so that's what led to further workup, but he has no symptoms and said, gosh, is this kind of wild scenario because I don't really feel anything. And that actually certainly happens in both non-small cell and small cell. Small cell does tend to grow more rapidly, and so more commonly people come in because of symptoms that have rapidly developed. And in some cases, that really can be people coming into the hospital because they're so short of breath, they suddenly need to be on oxygen. And so symptoms can really rapidly develop. Shortness of breath, cough, especially coughing up blood, that would be particularly concerning. The tough thing, though, is that often people have some degree of shortness of breath or have an intermittent cough anyway. That's something they've experienced before and it wasn't cancer then. Or they'll say, oh, I've had an intermittent cough for the last 10 years and now it's finally diagnosed as a lung cancer. Well, the small cell lung cancer hasn't been there for 10 years. And so oftentimes the symptoms that we talk about as being warning signs for possible lung cancer are actually symptoms that are more commonly other stuff. And so this is part of the challenge in screening, and really part of why lung screening is really so important. And people who are age 55, although more recently updated to age 50, with the amount of smoking history is something calculated, but you can ask your doctor about that. But if smoking is something that people have done for years, then they may qualify for that. And this is why lung screening is so important, is to really catch this when it's earlier before people are getting any kinds of symptoms.
Yeah, I'm really glad you mentioned screening because I think it is sort of this low-hanging fruit, and this option for, especially with the new sort of updated criteria and guidelines for, roughly 16 million people living in the United States today that qualify for screening. And the sooner we can find the cancer, the more likely we are to be able to cure it. So let's jump in. I want to kind of break this out, and you touched on it a little bit, into how small cell lung cancer is treated. And I want to start with limited stage. What role, and like I said, you touched on this, but what role does chemotherapy play, radiation therapy, chemoradiation, potentially surgery if that's ever an option, and what we call prophylactic cranial radiation?
Yeah, these are all different ways of treating. And basically what this comes down to, maybe let's start out with kind of the earliest. So first of all, I'll say chemotherapy is always a part of it, a part of the treatment. And I'll describe why in a moment. But if we're talking about a nodule that is found that ends up being small cell lung cancer, that's fairly uncommon, but does happen sometimes. To catch it that early is extremely fortunate because, as I said, this does tend to grow more quickly. But if someone gets surgery and it's small cell lung cancer, even if it's an early stage 1, whereas in non-small cell lung cancer, that would be considered it. For small cell lung cancer, we would still give chemotherapy. And some people say, well, the surgeon told me I got it all, so why would we be doing anything else? And I say, well, that's true. The surgeon is saying that we got everything we know of. And I often will give an analogy to help with this. So looking at these scans, and I still find it absolutely amazing that we can see inside people's bodies with these scans. The technology is like Star Trek. But at the same time, it's like if we were in outer space and looking at the Earth at night, and we see New York City light up, we see San Francisco light up, we see major cities light up. But there are plenty of towns that we can't see from outer space, even though there are people there are lights. It's just not enough to show up. And these scans with the cancer are the same way. With small cell lung cancer, there is a higher risk that some cells flicked off from that nodule and are somewhere in the body. We can't say that they're not there. We can't see them if they are. So we give the chemotherapy to really help eliminate any cells that remain. It's not perfect. It's not guaranteed, but it does increase the likelihood of really eliminating small numbers of cells that may exist. At the time of recurrence, that chemotherapy is not something that is really curative. But after a surgery, when it's microscopic out there, it does add to the likelihood of cure, and therefore is really important. Now, I should say, I mean, any of these I'm discussing, this is a broad subject. So if the decision with your doctor is different, that doesn't mean it's wrong necessarily. This is where we take individuals and we make decisions together based upon what's right for that individual, not just these kind of broad categories of starting points. So if there are lymph nodes involved, especially within the middle of the chest, this is very common within small cell lung cancer. Then chemotherapy and radiation is given with a goal of cure if there are no other sites of disease that have spread. And so chemo and radiation together, now the radiation is generally once a day, every day, Monday through Friday for 6 weeks, or could be twice a day, Monday through Friday for about 3 weeks as a way of giving this more condensed radiation. The chemotherapy is 4 cycles, and that's given 3 days in a row, every 3 weeks, essentially. But the chemo and radiation is given together with a goal of cure. Prophylactic cranial irradiation is a somewhat nuanced topic. Previously, this was the standard of care, and still is the standard of care, although now in question. It was previously the standard of care because there were studies that showed that when a group of patients, one was randomized to get radiation to the brain, and we say prophylactic, meaning that there's no known cancer in the brain, but you're radiating it to eliminate any microscopic disease. Just like I described with the chemotherapy, this was radiation to the brain to eliminate any potential microscopic disease. And the group that got the prophylactic cranial irradiation ended up having better survival. And so that's really compelling when we see a group of people live longer because of something. That being said, these were older studies, and there was not an MRI brain before before randomizing to the radiation or monitoring. And more recently, there was a study out of Japan that looked at doing MRI brain before that randomization, and then in the control group, meaning the group that did not get radiation, doing an MRI every 3 months. And really that ended up being, as far as a survival and standpoint, those were similar. So the group that did not get radiation prophylactically did end up having more cancers that showed up in the brain that were later treated, but that did not impact their survival in the longer run, it doesn't seem. Now, we can get into some of the statistics of that, and it's a little more nuanced than I'm presenting it right now, but that has certainly raised the question as to whether or not doing radiation is really so important if there's not anything known to be in the brain, or if just monitoring with scans is considered reasonable. And there's been kind of a general shift in not really doing as much of that prophylactic cranial irradiation, particularly in extensive stage disease. In limited stage disease, where we're really going for cure, I think there's still more of a tendency to give that treatment. The trial that I described out of Japan was an extensive stage disease, so that's not that curative intent setting. So there is an ongoing trial in the US now in both limited stage and extensive stage for a randomization to either getting prophylactic cranial irradiation or getting ongoing every 3-month MRI brain. And for some people, they feel strongly about either getting the radiation or not getting the radiation. And if people feel strongly about that, I think both are justifiable. For those who don't feel strongly and who say, well, we're not quite sure what to make of all of this, and therefore I'm willing to get either, then actually the trial is a great way to go. Now, extensive stage, the goal is not cure. And so extensive stage, the treatment is to knock back the cancer. In many cases, it really in many cases, people feel a lot better after starting the treatment, particularly if they have symptoms. So I described earlier, patients, some people end up coming into the hospital because they're having so much shortness of breath and end up having to be put on oxygen. And I've seen multiple instances where people came in severely short of breath, needing oxygen, where we start treatment and their shortness of breath improves to the point where they actually leave the hospital off of oxygen because it has worked so rapidly. Other symptoms that can come up, which I didn't describe earlier, can be swelling in the hands or neck and face. And that's because when you get that cancer in the chest, it can pinch off the big vein that goes back to the heart from the upper body in particular. And therefore, the blood is not really flowing as easily and kind of gets backed up. And that's where you get the swelling. And again, with the chemotherapy, that can resolve very rapidly as well.
Let's jump into some of the extensive stage stuff. And before we get into, some of the trials and the exciting things that are emerging, let's talk about the role of chemoradiation and immunotherapy, which is some of the newer drugs on the block to treat these patients.
Yeah, so for decades, we've had the chemo regimen, carboplatin or cisplatin, these platinum agents, plus etoposide are the two drugs. And that really has been the backbone, the standard first-line treatment. And really what we also give when we're talking about chemotherapy after surgery or chemotherapy with radiation, it's those drugs as well. At an extensive stage where we're talking about controlling the disease, it's also these platinum and etoposide. I think the general impression of the public and even many physicians not working in oncology is that people believe that when someone's diagnosed with a cancer, that chemo is going to destroy their quality of life, but give them more time. And if that were true, then being an oncologist would be the most horrific job, because if that were the case, you're really just making people suffer and for longer. And that is never actually the goal of the treatment. Everything is about quality of life. And many people are actually surprised that on the chemo, they don't experience nearly what they expect to experience from side effects. That's not to say there aren't any. And the treatment that I just described for small cell, people do lose their hair. Not all chemo causes people to lose their hair. For some people, that's a big deal. For some people, it's not. The amount of nausea is often dramatically less, or sometimes none at all, from what people expect. I think people picture what it was like decades ago, and so they expect to really have nausea be an ongoing terrible problem. Now, that sometimes happens. Thankfully, that's fairly rare. And most people really, if they get any nausea, it's fairly mild, and there's medicine that they take and then it goes away. And it's mild and lasts for a couple days, if that. As I said, sometimes there are bigger issues, but for most people that is better. Now, that chemo is given 3 days in a row, every 3 weeks. They do it 4 times and then stop. Generally, it was previously with chemotherapy, it was 4 to 6 times, and so there is a justification for cycles 5 and 6. I really was doing cycles 5 and 6 less and less, quite frankly, because I just think the benefit in that really diminishes. The only instances in which I would really more strongly consider that is someone who has no problems with the chemo treatment, and the scan after cycle 4 looks really quite a bit better than the scan after cycle 2. And the scan after cycle 2 often looks much better than the baseline scan. These are some nuances to this, but more recently, immunotherapy was approved. This is a few years back now. Immunotherapy was approved. Currently, FDA approved atezolizumab or durvalumab, both given with chemotherapy. We talk about the median, which is not quite the average, but we talk about the median. Now, the median isn't dramatically different when including these immunotherapy drugs, but the real benefit isn't demonstrated by the median. The real benefit is demonstrated by the number of people that really have ongoing control years out. And so we tend to look at these curves that show how many people have had recurrence or progression, the growth of their cancer. And what we see is that the group that got the immunotherapy drug, there is a higher number of patients that have ongoing years of disease control. And I have some patients that really were in, at this point, really, we're talking to really be like 5 years means they've been on one of those trials. But I do have some patients that really they are years out, and we're monitoring and doing what I call high 5 visits, where they're coming in and their scans look great. And now, the immunotherapy, when it works, is absolutely revolutionary. It is a home run drug. And really, I think where the biggest research need is in the group of patients that don't get the benefit, or better identifying who's really going to benefit from the immunotherapy and who is not, and finding better options for that group. We will not stop working at this until everyone has that home run, until all patients are cured. And there's a lot going on toward that, and there continues to be a lot of need for that, but we are getting some real wins in small cell lung cancer, which for decades has been really challenging. Non-small cell lung cancer, the last decade, this has become a totally new field in the last decade. Many of the drugs we're using in non-small cell lung cancer are new in the last 5 to 10 years. Small cell lung cancer, I think we're just starting to get these wins. And so the immunotherapy is a big one, but it's for a fraction of individuals.
Thanks, Jacob. And I'm really glad you talked about the side effects, sort of profile for some of these therapies, because I do know that people diagnosed with cancer are really afraid of chemotherapy, radiation. We talked about the cranial irradiation in a prophylactic way. I think it's so important, and I want to reiterate and drive home that it is not your grandfather or your great-grandfather's chemotherapy, that there are drugs that can help to counteract some of the side effects. And can you talk a little bit about what we normally refer to as palliative care, which is another word that tends to terrify patients, because they don't understand the supportive nature of it. Can you talk a little bit about the importance of that when you're being treated for small cell lung cancer?
Yeah, this is such a huge topic, really across all of oncology for all cancers. And to your point, this is not your grandparents or great grandparents' treatment. Even when the chemo drugs are the same as decades ago, our supportive drugs, our anti-nausea drugs, are so much better that even the chemo that previously caused such terrible nausea and vomiting now doesn't in nearly the same way, because of some of these anti-nausea medications we have. I think the general public impression, and even in medicine outside of oncologists, the impression is that a cancer diagnosis is a death sentence. In some cases, actually, no matter the stage, people are of this belief. Um, and that the treatments just make their lives miserable, but they live longer. And so there are, I mean, reinforcing this even within what we see in movies. There's the movie The Bucket List, which is this a delightful movie, actually. I mean, it's a great storyline, but it's something that further reinforces these preconceived ideas, which I often, in the beginning of my visits with people, I try to kind of break apart some of these preconceived ideas that actually don't help, and in some ways can be harmful to people's decision making. But Bucket List is a delightful movie. It's worth seeing. But it's a movie where a guy gets diagnosed with a cancer that can't be cured, and rather than get treatment, he decides to go off and have his life adventures for the time that he has. Um, and I think people are of this kind of belief that they can just carry on with their life, and when it's their time, it's their time, and without a real understanding of the fact that the cancer itself actually impacts people's quality of life quite a bit. And so people don't typically just have this kind of whatever time frame without symptoms, but rather the cancer itself causes problems. And so when giving the treatments, we're actually, the whole goal is improving people's quality of life. And there are times that the drugs themselves cause side effects. Absolutely. I'm not minimizing that, but rather just contrasting that with the fact that, on the flip side of that, they're often reducing the side effects of the cancer itself, or further delaying any of the symptoms that happen from the cancer itself. And um, so any chemotherapy or any really therapy being given is really about how much it's going to help somebody, how much it's going to improve how people feel, versus any risk of side effects that may come with it. And you weigh that out for each individual. And there are some individuals where I would not use a certain drug because of how they are, or any symptoms they might have at their baseline or their normal, and others where all options are on the table. Now, palliative involvement, you're right. I think for a lot of people, there's such a broad range of what people come in with, their preconceived ideas and understandings and experiences. In some cases, people think of palliative care as being end of life care, and that is an aspect of palliative care, but it's not the only thing. Palliative care really is around people feeling better. And so we we talk about chemotherapy as being palliative as well, because it's palliative is essentially focused on quality of life. Having the palliative care service involved can be end of life, but it doesn't need to be. And so sometimes what I'll say is supportive oncology, as terminology, where it's like, hey, we're involving other people who are really specialists around symptoms and discomforts and ways of further managing some of those. Thankfully, for most people that are getting chemotherapy, they tend to do okay with the treatments. And so having having palliative care involved isn't always something that's necessary. But in others, where they are having maybe a bit more symptoms or something else going on related, then having palliative care involved to better treat some of these symptoms can be very helpful.
There are so many complexities that go into this, and a couple of times you've mentioned sort of goals of care, and I think that's one thing, sadly, that is missing for a lot of patients, that sort of shared decision-making conversation with their physicians, right? Where the physician's not just treating the cancer, but the person. So that person first type of care is such an important piece, and clearly something that you partake in, and you have those conversations with your patients. Can you talk a little bit about what that might look like, or how a patient or person diagnosed with small cell lung cancer may not be receiving that, how they might go about starting that conversation with their healthcare provider?
This is a really challenging one, quite frankly. And it's one where um, when I started my career as an oncologist, really in fellowship, I went into fellowship thinking, okay, when I meet people, we just need to establish all of this stuff. And what I came to understand fairly quickly is that a cancer diagnosis is so much to process off the bat, and people come in with the preconceived ideas that I just mentioned. And so I honestly find that right off the bat, what we need to do is actually establish what's real. People come in with such strong preconceived ideas, and so some of it is really getting a sense of what they expect or what they think, and I do think there's a bit of a shell shock kind of a process in the diagnosis itself from the beginning. And so, frankly, when people come in with this preconceived idea that they now have a diagnosis where their time is going to be extremely limited and the treatment's going to harm them, and when people are holding those beliefs from the beginning to then jump into end of life kind of discussion, people that ends up it ends up unfortunately reinforcing these preconceived ideas that I think we need to first take a step back from. And so what I've found is actually to try to lay all of that out at the beginning is too challenging. And what people want for their end of life care is an extremely important aspect of things. So I'm not minimizing this in any way, but rather just saying that I think people often need to get their feet on the ground first and get to a point of kind of being like, okay, I have a cancer, which, as you know, just being able to get to the point of saying, okay, I have a cancer is in a somewhat unfathomable amount to process. But before getting to that, it can be really hard to have uh, um, real solid end of life type discussion, because at the same time, I think people come in thinking that that's what's going to happen right now, and recognizing, hey, you might very well start your treatment and do really well, and you could go on. And I have patients who a certain time frame into their treatment will come in and say, gosh, I have days where I don't even remember I have cancer anymore, which is kind of a wild statement. So so I honestly find that in the beginning, what I'm trying to help people do first is, rather than have cancer be everything they think about, is get back to themselves being the same person they were before they got diagnosed, getting their feet on the ground, having activities that are focused just on the cancer, having stuff they think about, stuff they accomplish, stuff they do, kind of getting back a bit to the rhythm of life. Now, that's not how it goes for everybody. This is a very individual path. There are time points at which it's extraordinarily important to really get down to brass tacks. And that is an individual path. And each individual, depending on where they're at, where their mindset is, how they're interacting, is what defines this interaction from me. One of the things I always tell people is I will always be very direct with you. Any question you ask, I will be as blunt as I can in my answers. Um, I will never say things just to provide hope. We're going to talk facts. And there will be times that I may say to you, this is a terrible situation. Because if it is, I'm just going to tell you. We're not going to pretend things are amazing when they're not. I will be absolutely direct with you. And it also comes down to when a conversation is going to be something where you're making decisions. One of the most, maybe the most common question I get even especially in the very beginning, is essentially, how long is this going to work? How long do I have? This type of question. I mean, even in providing as blunt and direct an answer as I can, you just can't say for any one individual. And as I've said, I have people that are years out. So it's impossible to provide that. And so I'm very direct about the fact that that's unanswerable. Um, but but when it gets down to, hey, here's the situation in my life, and I need to make some actual life decisions based upon this type of thing, then we talk statistics and all of this in the context of what matters for that individual. And so this end of life discussions is really important within the context of each individual as well. And so this is it's a very individual process, I guess, is what I'm getting down to. And to make broad sweeping kind of a recommendation, it's such a challenging subject, quite frankly.
Okay, let's jump into some of the exciting things that are going on. But I want to ask first, I think in non-small cell lung cancer in particular, you mentioned over the last decade or so, a lot of things have happened. A lot of new therapies, particularly targeted therapies based on biomarker status, have been approved. Are there currently any biomarkers used in treating small cell lung cancer, or are any emerging?
Yes. This is a very exciting thing within lung cancer now. So in non-small cell lung cancer, we have various subtypes that have been described. That was years back. And as I said, within the last 10 years, we've had dramatic advances within non-small cell lung cancer related to different subtypes, but each of them really impacted by these different treatments. And within small cell lung cancer, we really just have small cell lung cancer. But more recently, there are very similar proposed subtypes, really from Charlie Rudin at Memorial Sloan Kettering and out of Lauren Byers' lab at MD Anderson, where they both described, as I said, similar proposed subtyping of small cell lung cancer. Now, right now, that isn't something that is something that would impact treatment options, but there is more going on within small cell lung cancer treatment studies than probably the culmination of everything that has previously been done, which is just to say there is a ton of research happening right now in small cell lung cancer. There are a number of novel therapies in trials, and these proposed subtypes may have a significant impact as to which groups might respond better or have cancers that respond better to these different novel therapies. And so we'll see how this pans out, but this may provide a new framework upon which these novel treatments will hopefully move forward and really become approved treatment options. And subtyping might be a way that will better identify cancers that can respond to other novel therapies.
It is very exciting. I know we're talking about research now, right? And I think historically there may have been some limitations on studying small cell lung cancer. Can you talk a little bit about that and how that may have impacted sort of the lack of major therapeutic advances in the last 30 years, although that's changing now?
Yeah, so small cell lung cancer has been tough, in part because it grows so rapidly. People really need to start treatment immediately. Now again, that's not true for absolutely everybody. So, but more commonly, people need to start their treatment quickly, and so therefore, it can be a bit more challenging to go through the process of referral and enrollment to trials and such. Um, at the same time, the amount of tissue available is often quite a bit less in that the biopsy within small cell lung cancer, there tends to be a bit more of what's called necrosis, which is dead cells. And so the amount of tissue that's really available for testing is often less. Now, a lot of the genomics type stuff that has developed and really the subtyping has in part come from genomics testing, although the way of categorizing is now from stains on the surface of the cells. But the genomics evaluation that is done, the technology on that has really advanced quite dramatically. There are still some challenges for clinical trials within small cell lung cancer, and this is where um, getting referred or being seen at one of the big academic centers that has trials available is really important. Even if you've already started treatment, I would say it's still worth finding out who has trials options in the area, because at the time of progression of the cancer, that can be when you really need that option. And so it's just good to be plugged in somewhere where you have a sense of not necessarily the specific trials, because that will change with time, but the process of it, so that you're kind of ready to be plugged in as needed.
So, what types of clinical trials are available for patients with small cell lung cancer, and what type of promise are they showing?
Right now, there are studies, and this is not just small cell, but antibody drug conjugates is a category where essentially it's an antibody, so something that binds to the receptor of a cell, and it has a linker to what's called a payload, which is often a kind of chemotherapy. But what this essentially does is binds to the surface receptor and typically it's a receptor that's really on cancer cells, so that it gets pulled into the cancer cell where the payload gets released. And essentially it's a way of delivering the chemotherapy into the cancer cells rather than just giving it as an infusion that goes everywhere throughout the body. And so these are drugs that tend to be pretty well tolerated. The side effect profile is really very good in these because it's really a focused treatment of the chemo. And there are trials within small cell lung cancer that are antibody drug conjugates. There are other trials that are with immunotherapy. And so I have a couple of these trials open where we're really seeing some extraordinary responses in. So these are patients that have already gotten chemotherapy and the immunotherapy drugs that we talked about earlier, and the cancer grows. And now there are at least a couple of different drugs where they're binding. It has an antibody, so that's something that binds to the receptor of T cell, so in the immune system, and binds to the cancer cell. So it essentially pulls the cancer cell and the immune cell together and then creates that immune response. Again, then we're seeing patients that have an immune response that then fights the cancer. I should say, I didn't really say this earlier, but the immunotherapy drugs we described earlier, durvalumab and atezolizumab, that are approved in the first line treatment of extensive stage small cell. These drugs are not toxins. They're not something that harms cells. In fact, those drugs themselves don't treat the cancer, but what they do is to help the immune system recognize the cancer so that the immune system actually fights the cancer. And these drugs I'm describing now that have bind to the T cells, the immune system, and bind to the cancer cells are also creating that immune response to the cancer. So we are seeing some people that are having a really nice response. Now, in the immunotherapy I described earlier, that is part of the first line standard of care with extensive stage small cell. What I had said is that it's a fraction of patients that really seem to get that benefit, but that benefit's a home run. Some of these people are really having years of control of their cancer and often with minimal side effects, thankfully. That's not to say there aren't people that sometimes have more in the way of side effects, but as a broad statement, I can say often minimal side effects. But those are two different classes of drugs that we're seeing in trials. Now, but there are more. I mean, there are other pathways that are being treated, and this could be an hour long talk in itself. But then that's getting back to these array of treatments. When we subtype out small cell lung cancer, is that something where we'll see some of these drugs work better for some subtypes than others? This is ongoing work.
It's important to talk to your physician about clinical trials, right? Because in order for us to generate discovery and new treatment options for lung cancer patients, we need people to join these trials, right?
Yeah, I
Breathing.
mean, that's absolutely true. I also always stress to people that when we're talking about any treatment for that individual, including trials, it is only within the context of what's good for them. That we do not do treatment trials for people in the future. Now, sometimes there are studies where we say, oh, can we collect another tube of blood or something like that for doing studies to hopefully develop something. But when we're talking about a clinical trial, enrolling on a treatment trial, I only talk about what I think is the best option for that individual. And even on the trial, if I think for whatever reason that's no longer their best option, I will take them off the trial. Anything we do from a treatment standpoint is about what is best for that individual. We of course hope that the treatment works really well and therefore goes on to help other people, but it's not about other people. And people, I mean, for any patients watching, any treatment you get should be all about what is best for you.
Similarly to some patient fears around chemotherapy or side effects from treatments, it's the same here. People are afraid of the old, sugar pill or placebo. Can you talk a little bit about how trials are run today and how that's very rarely the way it
Yeah,
works?
that's such an important point. Thank you for specifically bringing that up, because that's right. I mean, just like in the beginning I talked about the preconceived ideas around cancer, the preconceived ideas around what trials means is also often very strong. And people come in with the belief that trials are done when there are no treatment options, and that trials they might just get a sugar pill, which is not even treatment. And both of those are not really the case. So in the first line, we discussed chemotherapy plus immunotherapy as being the standard of care now, and that's because of clinical trials that only recently were reported out. And this was, people got randomized to get the first line chemotherapy or the chemotherapy plus the immunotherapy. In one of the trials, it did incorporate a placebo, but that was the chemotherapy plus a placebo. No one would be getting just a placebo. And that's a really important point. Any treatment on a trial is going to be at a minimum the best standard of care. So there are trials where everyone is getting the study drug. And that's only when we have data to suggest that this is likely going to be effective, where we're optimistic about this working for people. In a randomized trial, if they'd be getting the control, which at a minimum is the best standard of care. So there aren't really trials where people would only be getting a placebo. It wouldn't be ethical unless there are truly no treatment options. And so I think this really comes from back in the era decades ago where we didn't really have treatments for cancer. And so we were comparing, I mean, I say we, but this is before my time, but we as a field were comparing placebo because there weren't known treatments with a treatment. But we're so far beyond that right now.
Yeah, thank you. I always try to clear that up because I think it is a reason that patients don't look into clinical trials or even want to have the discussion with their physicians. Another thing that I wanted to give a shout out about is GO2 Foundation began an initiative specific to small cell lung cancer last year with the goal of educating, supporting, and engaging the small cell lung cancer community for improved outcomes and quality of life, just what we're talking about today. I think we've heard from our community, our small cell community through focus groups, that there are challenges around this particular subset of lung cancer finding good information, relevant information, up-to-date information. They type in small cell, Dr. Google, as much as we tell patients not to go there, they go. And when you type in small cell lung cancer, you have to weed through all the non-small cell lung cancer stuff first to be able to find it. So we're working really hard by creating new education materials and videos on staging, breakouts on immunotherapy specific to small cell lung cancer, a breakout of our comprehensive patient education handbook that's specific to small cell lung cancer, brain metastases, side effects, all that good stuff. We have a qualitative study going on with Dr. Christine Lovely at Vanderbilt. We're creating a specific landing page on our website, a specific online community just for those folks with small cell lung cancer, enhanced content on our registry and newsletter. So we've got a lot of great stuff going on. So please don't hesitate to reach out to us to be able to help sort of, help you to gather a better understanding of what your options are and some of the things that Dr. Sands is talking about today. I think some of the take-home points are where I'd like to close with, and that is there's reasons to be optimistic. Second-line therapies, research and trials, And Dr. Sands is very quick to say, please stay offline.
I'm okay with people looking online, but you should bring your questions into your doctor because there's just so much misinformation out there or stuff that really doesn't relate to your specific case. So just be in close touch with your doctor and feel empowered to say anything. We just touched on stigma. I know people have a smoking history and there's often a guilt about that. It doesn't matter. It doesn't matter why you're here. You're here, let's move forward. And you should always feel empowered to communicate whatever you're thinking. Any questions, any comments?
Thank you so very much to Dr. Sands for coming and talking with us today about some of these new and novel approaches to small cell lung cancer, obviously to Medscape for allowing us this time during the virtual lung cancer conference, all of you watching live and all of you that will come back and watch post-live, Peninsula Television, and the entire staff at GO2 Foundation for all their support. Everybody enjoy the rest of your day, and hopefully we'll see you soon.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.